These are a few surgical pearls for presbyopic IOLs. We need to understand how to give the maximum benefit of presbyopic IOLs to the patient, and surgical technique and what we follow during surgery is very important. Pearls develop over a period of time. Incision, rhexis, pupillary centration, small pupil, capsule polishing, final IOL placement, these are the most important points. Last but not the least is a good phacoemulsification technique as well. Incision, preferably you need to start planning your position. So your hands should be relaxed, because if you're going to have a cramped up position, you're going to be lifting up the lip, you're going to induce an SIA. Double incisions, as in you've had a premature entry, you're coming out, making another entry, is going to change your SIA. So that's again going to change your outcome. Use new blades, that's going to give you consistent results. You need to have good square MICS incisions of less than 2.4, because your centroid SIA is going to be around 0.1 with these kind of this ones, and more predictable outcomes. With the CCC, the corneal rhexis markers or the varus or the varion is something that you should start off with, because estimation of your 5 or a 5.5 may not always be right and may not always be centering around the Purkinje images. I prefer doing the rhexis around the visual axis on the varion, but you can do it around the center of the pupil as well, but slightly nasally. You need to see to it that 360 degrees coverage of the IOL edge happens, because that's really going to center your IOL well. An inadequate coverage or a decentered CCC is not acceptable in presbyopic IOLs, though it happens in everybody's hands once in a while, because it over a period of time decenters the IOL and causes those kind of issues. Definitely flax, the CCC is very well centered and it's consistent with the size, but that's perfect, not a problem. Capsule polishing, again, we used to do a lot of anterior-capsular polishing, but over a period of time we've known that it's not really important. Most important is the posterior capsular polishing, because you need to remove off those Elschnig pearls. I am doing showing it here with a bimanual on this, but that's okay. You can do it with a hydro cannula, you can do it with anything, but please polish the PC well, because presbyopic IOLs, you're charging a lot, and if the patient comes back with a PCO within just a few days or months, usually cribs about it quite a bit. You need to check your IA tips pretty regularly, because over a period, whenever you're cleaning them, you do get ragged edges on the IOL tips, like what I am doing out here, and you tend to get a PC tear. And in case you do get anything of these sorts, please convert it into a posterior capsular rhexis, and in that case you can easily put a presbyopic correcting IOL in spite of the rent out there. So here I'm using a capsular rhexis forceps, microcapsular rhexis forceps. I'm pulling up the capsule up because there's no vitreous out there. I've used a dispersive viscoelastic to do the PCCC, and I'm going to complete the PCCC out here and then put in the IOL there. So though this is a toric IOL which I have put, you can always put in a presbyopic IOL there as well. These plaques are also important. They can be easily removed. You need to be very careful or have a good microscope, but you can peel these plaques off the PC. If there's a gap which is left between the plaque and the IOL, the epithelial front can grow behind and cause a PCO, early PCO. And if there is a doubt of any zonular dialysis, it's always better to put a CTR. So even if there's a loose bag, during your polishing you realize that the bag is moving slightly, there's no harm in putting in a CTR, because it's going to prevent the entire IOL back complex from getting dislocated anywhere. The IOL placement is very important here, and you need to center it pretty well. For the toric IOLs, you can use a needle to do the markings on the slit lamp, stain them with the trypan blue stain, and they stay there pretty well, and you can actually have a very sharp marking there. See to it that your wound leakages are not happening, because that can change the position of the toric IOLs. The center of the pupil and the first pupillary image, the angle kappa, is very important. So what I do is I usually try to center it between the two Purkinje images, and that's usually the best possible estimation of the visual axis. And please remove the viscoelastic behind the IOL, because that can change your immediate post-op outcomes, as well as it's going to prevent secondary surgery in the immediate post-op period as well. And as I said, obviously a good phaco technique is very important. Small pupil, a boon or a bane, we don't know, but anything less than 2.5 millimeters, please tread with caution. Manage the pupil without causing a sphincter tear. It would cause an atonic pupil, and if a presbyopic IOL is put in such cases, it's not going to really work to its optimum. Avoid hooks. You can use a B-hex or a Malugin ring. That's very safe on the pupil. Have faith in technology and conviction in your advice and surgery. Thank you.
Thank you, Dr. ABHIJEET, for such a lucid explanation.